As well as graduating from UCSF School of Nursing, I also had the pleasure of being a part of the Leadership in Adolescent Health program, which really helped to stem some of my interest in these topics. So we will just go ahead and get started. This discussion will be about the impact of health-related stigma in adolescents and young adults with sickle cell disease. And I would like to start off with a video.
Hey, line up, everybody line up. We're about to race. Everybody line up. Shoulder to shoulder, take off your backpacks. Basketball, line up, we're about to race. Hey, we are racing for a $100 bill. The winner of this race will take this. It's a $100 bill. Before I say go, I'm going to make a couple statements. If those statements apply to you, I want you to take 2 steps forward. If those statements don't apply to you, I want you to stay right where you're at. Take 2 steps forward if both of your parents are still married. Take 2 steps forward if you grew up with a father figure in the home. Take 2 steps forward if you had access to a private education. Take 2 steps forward if you had access to a free tutor growing up. Take 2 steps forward if you've never had to worry about your cell phone being shut off. Take 2 steps forward if you've never had to help mom or dad with the bills. Take 2 steps forward if it wasn't because of your athletic ability, you don't have to pay for college. Take 2 steps forward if you never wondered where your next meal was going to come from. I want you guys up here in the front just to turn around and look. Every statement I've made has nothing to do with anything any of you have done. Has nothing to do with decisions you've made. Everything I have said has nothing to do with what you've done. We all know these people up here have a better opportunity to win this $100. Does that mean these people back here can't race? No. We would be foolish to not realize we've been given more opportunity. We don't want to recognize that we've been given a head start. But the reality is we have. Now, there's no excuse. They still got to run their race. You still got to run your race. But whoever wins this $100, I think it'd be extremely foolish of you not to utilize that and learn more about somebody else's story. Because the reality is, if this was a fair race and everybody was back on that line, I guarantee you some of these black dudes would smoke all of you. And it's only because you have this big of a head start that you're possibly going to win this race called life. That is a picture of life, ladies and gentlemen. Nothing you've done has put you in the lead that you're in right now. When I say go, on your mark, get set, go. Hey, line up.
So that video was shared with me when I was in the Leadership in Adolescent Health program. I had the opportunity to work in the juvenile justice system. And I feel like this video can be used to kind of just show that everyone's race is different. Our starting place in our race is different. The things that we've been through in life, our familial upbringing, they all make a huge impact on our race of life and how we deal with things around us. And so I just think as we go through this presentation, just remembering this video and some of the things that this population goes through will really help us as clinicians to be able to understand how to better care for this population. So overall, we're going to be discussing quick overview about sickle cell disease, discuss some of the history of sickle cell disease, define a couple of terms, including health-related stigma, racial bias, and racism. We will also discuss stigma and its impact on adolescents and young adults with sickle cell disease, and discuss ways that as providers, whatever role you play, how we can help to reduce that in this population. So sickle cell disease is an umbrella term it encompasses multiple hemoglobinopathies. And for the purpose of this talk, we're going to be primarily talking about sickle cell anemia, as it accounts for 60 to 70% of sickle cell disease. And with pain being one of the lead characteristics of this illness, it is one of the most severe phenotypes as well. So we're going to primarily focus on sickle cell anemia. 1 out of 500 Black children in the United States are born with sickle cell anemia. A lot of the literature also says, up to 1 out of 365 Black children are born with sickle cell anemia. Acute pain is the hallmark clinical characteristic of sickle cell anemia due to the abnormal sickle cell-shaped red blood cells that disrupt blood flow, causing ischemia, inflammation, acute pain crisis, as well as infection. There's been some therapeutic modalities that help to increase the lifespan in this population, including hydroxyurea and prophylactic penicillin, as well as vaccinations and transfusions have contributed to increasing the life expectancy of this population. And most adolescents will live until 98.4 to 99% of adolescents will live until they're 18, but many adolescents and young adults are living from anywhere between age 44 into their 50s now, because of some of these therapeutic modalities that research has helped us to find. This is just another quick picture showing the pathophysiologic detriments of sickle cell anemia and how it can cause occlusion in the vessels and can lead to infection, infarction in the vascular system. Some complications that young adults and adolescents with sickle cell anemia face is stroke, acute chest syndrome, neurocognitive disabilities, growth delay, acute and recurrent pain crisis, organ dysfunction, infection, renal disease. I mean, this list goes on. The list and information is so much longer than this. These are just to name a few. But one thing that I will say about some of these complications that you see, some of these, like including stroke and acute chest syndrome, a lot of these present in the acute care setting as pain because of the pathophysiology of the red blood cell. While this population can die from things like stroke and acute chest syndrome, sometimes the only first symptom is pain. And so just thinking as clinicians on how to be more aware of that when someone presents with pain, because there could be significant underlying medical pathophysiology that is also contributing to the pain as well. Also including with increased life expectancy, since this population is living a lot longer, they deal with disparities in social and economic as well as health burdens. So it's something to think about too. This is just to go over the genetics of the different phenotypes of sickle cell disease. Okay, another video. Everyone loves Bill Nye the Science Guy. So I'm gonna play this really quickly.
Now here's the same map of the same continent with just one color. And it turns out that everybody on Earth is descended from people that live here. in Africa. And then as groups of us moved around the world, the color of our skin had to change. And here's why. Our skin is where we make vitamin D. If you don't get enough ultraviolet, you don't get enough vitamin D. But if you get too much ultraviolet, then you break down your folates. You have to have it in perfect balance. And because the ultraviolet varies, the color of our skin varies. And that's it, everybody. That's why we have different colored skin. But we're all one species. But we're not treating each other fairly. Not everybody's getting an even shake. So it's time to change things.
So to go into some history about sickle cell disease, Akakufulobi was another name that translated to he will die tomorrow. And in low resource countries, some children don't live until even the age of 5. And while this population here is living until they're at least 18, but some were upward to their 50s. There was negative beliefs of inferiority that were associated with sickle cell disease because of the African descent of this disease. It was historically labeled as having bad blood, and it was neglected. It was noted to be the neglected genetic disease because there was so little public attention and funding for this illness. This timeline, some important dates here about sickle cell disease is that it was first described by James Herrick in 1910. And you see that the pathophysiology described from 1910 even upwards to the 1970s. In 1971, the first sickle cell disease clinic was created in Memphis, Tennessee. And then in 1972, the Sickle Cell Anemia Control Act was signed into law. And this really helped to drive funding for sickle cell disease, increased funding, increased comprehensive care centers that really played a huge role in some of these therapeutic modalities that have come up to help this population. What I found to be really interesting while researching this topic is that the Tuskegee syphilis case ended in 1972, and that was a popular study where Black people were used without informed consent they were also told that they were being treated for bad blood, and they were used to identify how to treat syphilis. And so it's interesting because that study ended in 1972, and then you see this turn for change, not only with the Sickle Cell Anemia Control Act, but even a year before that, the Black Panther Party really began to drive for equitable healthcare services for the Black population. And on my next slide, we'll talk a little bit more about the Black Panther Party, but they also were going into the community to really start screening for sickle cell anemia as well. So New York was the first state to implement universal newborn screening for sickle cell disease. In 1982 was the first stem cell transplant that noted to cure sickle cell anemia. In 1983, the prophylactic penicillin study was such an important study because they stopped the study early because it showed such a reduction in infection in this population. I also put California on here just to show it took almost 30 years from around the early 1970s till 2006 before newborn screening for hemoglobinopathies was required in all 50 states. And then also in 1995, there was another study about hydroxyurea that showed incredible outcomes with pain reduction in this population. So these are just some important dates, and there's many more, of course. But this shows this transitionary period in research and collaboration and comprehensive care for this population. Some cool pictures I found online that just shows that the Black Panther Party went into communities. They were really advocating not only for equitable care, but they were kind of working on reducing police brutality, some of the same things that we see with young Black adolescents and adults right now. And this is just a picture timeline that you see once the National Sickle Cell Control Act was implemented. You see this dramatic increase in life expectancy in this population. There's preventative penicillin as well as hydroxyurea. So prior to this, their lifespan, which was much shorter, and after there was this push for funding, we see an increase in life expectancy. So this time period played a huge role in the sickle cell disease population. On to definitions. The definition of health-related stigma is a multi-level process involving labeling another one as different or undesirable on the basis of stereotyping, discrimination, devaluation, exercise of power, race, cultural background, and disease status. And this definition is very similar across many literature platforms. Racism, I really like the definition from the American Academy of Pediatrics. This paper came out in 2019 that defined it as a system of structuring opportunity and assigning a value based on social interpretation of how one looks that unfairly disadvantages some individuals and communities and unfairly advantages others, and saps the strength of the whole society through a waste of human resources. And as we know, racism is a social determinant of health, a social construct that really impacts the health status of children, adolescents, and emerging adults and their families, not just in the sickle cell population, but across health for adolescents and young adults across the whole health platform. Bias are attitudes, associations, of beliefs towards individuals and social groups that affect one's feelings, actions, and understanding and decisions. So bias can drive, as clinicians, the care that we give, and sometimes that's implicit. Sometimes we don't know that, or it's just kind of unconscious that we have this, it's not plainly expressed, but it's unconscious that we have this bias. And sometimes it's just clear and abrupt, and it's an explicit act of discrimination against one population rather than another. These definitions that you see here, I received from the adolescent division at UCSF, this anti-racism and race literacy toolkit that goes through, like, I think it's a 4-step process on how, as clinical providers, we can help to be aware of our own bias and reduce these biases so that we can give equitable care to everyone that we see. So if anyone is interested in having that, let me know and I can email it to you. Institutionalized racism are policies, practices, and procedures that work better for white people than for people of color, regardless of intention. And to kind of highlight this, there's some adult facilities or other facilities across the country that don't have, we're lucky enough here at Children's Hospital Oakland to have a pain procedure plan for sickle cell anemia protocol that we use in the emergency department, but there's a lot of facilities that don't have a policy or plan in place, and that don't have protocols that include adequate pain management for this population. And the institutionalized racism aspect of things is that there may be protocols in place that help certain populations with certain illnesses, yet a lot of facilities still don't have policies or practices to standardize care for the sickle cell disease population. So it's important to kind of, you know, as a clinician or provider, ask, does our institution support an environment that's going to be inclusive and that is going to really drive equitable care for all populations? Equality is a state or outcome that is the same among different groups of people. Equality is sameness, while equity is the process by which resources are distributed according to need, and that's fairness. And this is a pretty popular photo. I'm sure that everyone's seen it. In regard to sickle cell disease, This kind of reminds me of the funding aspect things. So in regard to prevalence, there's about 90 to 100,000 people in the United States living with sickle cell disease. There's about 30,000 people living with cystic fibrosis. So when you compare these two, sickle cell disease impacts people of color, primarily Black people, while cystic fibrosis primarily impacts the Caucasian population. And despite the prevalence difference, 100,000 people versus 30,000, over time, we've seen that there's been chronically less funding for sickle cell disease than there has been for cystic fibrosis. And this includes federal funding as well as private funding. And with that being said, funding drives pharmaceuticals. It drives the research, comprehensive care centers, and overall impacts the health of the populations at hand. Which is why on a previous slide, you see such an incline after there was a lot more funding in the 1970s for sickle cell disease. You see this dramatic increase in life expectancy because once we had the resources to really educate ourselves about it and to research things, we were able to put practices in place that help to increase life expectancy. Again, this is just for visual learners. This just gives an example of the difference between explicit and implicit institutionalized racism as well as individual bias. Bias. On this, I know this is a very busy slide, but if you just see where my cursor is pointing, starts in 2008, we end in 2017, and this is NIH funding. So this is federal funding for sickle cell disease and cystic fibrosis. And you see from 2008 all the way down to 2015, there was less funding for sickle cell disease than there was for cystic fibrosis, despite that prevalence that we talked about, despite the number of people that are impacted by this disease. And so this just goes back to the equitable definition. Are we as a community in research, and are we giving equitable care services to the population who needs it? This vaso-occlusive crisis 8-phase phenomenon, I wanted to bring this up to make a little bit of a point, especially from an emergency department standpoint. There's this idea that there's this process where typically there's a precipitated factor to pain crisis, and that can start with dehydration, illness, sometimes weather can impact patients who have sickle cell pain crisis. You start with this prodrome, you transition into a mild pain, it gets more moderate, and a lot of times in the emergency department, we only see a subset of this population during severe pain crisis. And it's not well understood in the literature, but adolescents and young adults anywhere from age 18 to 30 years old, during this developmental stage, they have increased sickle cell disease complications. And it hasn't been clearly understood, but this is acute pain in this population is why most adolescents and young adults go to the emergency department. And a lot of times we only see them in this phase, this severe phase. We don't recognize that sometimes after a severe pain episode in the emergency department, they're being admitted, and then again, their pain continues to decrease, and they go back to baseline. Some of my colleagues have kind of brought up a point where, like, if someone comes into the emergency department with a broken arm, they're in pain, we give them pain meds, we fix their broken arm, we cast them, we send them home. And so a lot of times we feel like we've gained something when we're able to see something from start to finish. But with this population, sometimes it's a longer phase, it's a longer process. It's not going to be a 2 to 3 hour fix. This is a chronic illness that can last a lot longer. We don't always see that finish line in the emergency department. Also, prior to this severe stage, we don't recognize that with increased emergency department visits during this developmental period, they may have tried everything they can do at home to reduce their need to come into the emergency department. So maybe they've failed their home regimen. Maybe they've been following up appropriately outpatient, but they just can't get a grasp on things. And so not only can that impact their visits to the emergency department, but a lot of times it's their previous experience with health-related stigma and bias where they wait till the last minute to come into the ER because they've been treated poorly before, or they've been discriminated against before, or they've been kicked out before. And so this is just such a complex process that as clinicians, we have to be mindful of the bigger picture and not just focusing in on, we have to give more comprehensive and complex care to this population. So this slide was some interesting facts, as I feel like researching this topic was super fun to me because it's like a rabbit hole. You kind of go down it and you disappear, and there's so much information that you start to gather. But there was a research study done with medical students, and the first line where it says Black people have thicker skin and have less pain than white people, there was first, second, third year residents, as well as med students, first, second, third year med students, as well as some residents, that more than 50%, they gave a list of what was it? They gave a list of just kind of misconceptions of Black people in regard to pain. And the students were able to identify whether they thought some of these things that were untrue were, whether or not they had thought they were true, more likely true, not very likely true. And so greater than 50% of medical students endorsed at least one false belief about Black people and pain, and some of these misconceptions. So even in the medical community, there's just more learning to be done. Black adults are less likely to receive opioid pain management than their non-Hispanic white counterparts in the emergency department for various medical complaints. There's several studies about this. One was about extremity pain. And then another study was just about generalized pain, abdominal pain. But in comparison to their white counterparts, they receive less opioid pain management. I also found it to be fascinating that there was a study of almost 1 million children who had appendicitis, and they looked at their race and ethnicity, what their pain levels were, and the amount of medication that they received. And it was noted that in this population, Black children were less likely than white children to receive pain medication despite having the same pain level, same severe pain level. And so there are these disparities, and the data shows that there's disparities in pain-based care. In the literature, some of the stigma ideas are that these patients are frequent flyers. And again, just to note that adolescents and young adults require more hospitalizations from adolescence to adulthood because for an unknown reason, they have increased complications during this period. And so it's between those ages that they're most seen in the emergency department. So it seems like they're there a lot more often. They often are called drug seekers, that they're because they know their pain medication regimen. Sometimes we see adolescents and young adults in the ER who say, oh, I usually start off with a dose of Dilaudid. And whereas this is an opioid, we use opioids to treat sickle cell disease, we wouldn't have the same judgment or the same ideas or beliefs about someone if they came in and said, oh, I have asthma, but I tried my inhaler this morning and I usually take my inhaler twice a day. Their research has shown that they aren't as stigmatized as this population. Clock Watcher, the literature says that when adolescents and young adults know when it's time to receive their next dose of medication, this is frowned upon by providers. They feel like they're watching the clock so that they can tell them that they need another dose of pain meds, and increase ED wait times. And that is just to go back to the pathophysiology of sickle cell disease often presents with the same symptom, which is pain. So whether or not it's stroke, acute chest syndrome, abdominal pain, which could very well be a severe emergent condition like acute chest or abdominal pain for like, any spleen sequestration. A lot of these have pain as a primary symptom. And despite that, they've seen increased ED wait times in this population. The facts from the literature are that health-related stigma can result in poor medical treatment, premature hospital discharge, and increased ER wait times. A qualitative study showed that sometimes adolescents and young adults with sickle cell, they blame themselves and they also stigmatize themselves. They're not as willing to talk about their disease with their peers for fear of like judgment from others. There was also a qualitative study that identified that parents of children with sickle cell disease, they feel like there's a lack of knowledge in the academic, medical, and those settings, as well as general societal functioning. And some parents also said that they felt embarrassed to tell family members what was going on with their child, or they often stigmatize their own child sometimes. Stigma can be intertwined with racism, and we see that in the history of sickle cell disease as a whole. Adolescents and young adults with sickle cell disease have decreased employment opportunities. They have lower income and economic status than healthy adolescents their age, lower educational completion. There was a study that showed that 70% of adolescents and young adults with sickle cell disease reported moderate to high sickle cell disease related stigma. And there's also this literature that talks about having sickle cell disease related stigma, but also race-based discrimination, and how those kind of intertwine as well. The impact of stigma-related healthcare, it delays patients from seeking healthcare earlier in their illness. They don't want to come to the ER because they've been treated poorly before, or they don't want to show up again because they feel like they weren't listened to. There is provider bias. In an intervention study, there was an increase in provider bias amongst a intervention group. And so even these providers endorsed having bias about their patients having drug-seeking behaviors. Adolescents with sickle cell disease feels like their opinions aren't heard when they talk about their disease, even though we find it to be rewarding when someone else knows their pain or knows their medication regimen or knows their illness and their disease process. In this population, they feel like their opinions aren't heard, even though they are well aware of their own body and their own illness. Patients with sickle cell disease feel judged for knowing their pain regimen, and just some objective quantitative information on some of the studies I read were just that higher perceived stigma was associated with higher pain. Higher perceived stigma was associated with lower pain reduction. Higher perceived stigma in this population was associated in lower quality of life. And this was in physical areas, as well as mental health status, and also health perceived stigma was associated with increased length of stay. So as clinicians, what can we do to dismantle health-related stigma? First, it starts with yourself, educating yourself. It was really, really interesting to me to start to go through the literature because it's endless. The information that I found was endless. So I was able to educate myself and move on to educating others, and hope that this can be a discussion that really opens up more discussions in the future about how health-related stigma impacts the sickle cell disease population, but how it impacts other populations as well, and overall health. Being aware of your own bias, the race literacy and health toolkit is a great tool that was made for medical professionals to really start to understand, like, what are some of my biases? How do I apply those to the care that I give? Standardizing care, there's been many studies that show that when we have standard operating procedures or protocols, that it removes the judgment from the care that we give and allows to give a standard care to everybody. And we're lucky enough to have a team where most of the adolescents and young adults with sickle cell disease that come into RER have patient-specific protocols and pain plans that help us to standardize that. So we know each time that they come in, that here's what we do and here's how we can manage their care. And we also do have just a general protocol as well. And advocating for our patients. In one of the intervention studies that I reviewed, it was really interesting because one of the groups was supposed to be a control group, but in the control group, they actually did like life interviews. So the doctor and the patient together did life interviews. And what's interesting is that perceived bias and stigma in the control group, which was the life experience group, it reduced over 3 time periods. And so I think the importance of that is just being able to have these conversations with your provider and discuss some of the stigmatization that they've been through before, or just their general experience with having sickle cell disease, really help to reduce their perceived stigma. And I won't forget, as a nurse in the emergency department here, I had someone come in and I just sat down and we were just talking for a while. And this young adult told me, Aubrey, I don't know what I would have done, like, if I didn't have sickle cell disease, because there was a point in her life that she came into the ER because she had sickle cell disease and had pain, and they allowed, I think this was a long time ago, but they allowed like some of the siblings to stay in the ER with her. And long story short, she was like, my mom was on drugs at the time and I didn't have a place to live. And we were on the streets, me and my siblings. And if it wasn't for having had sickle cell disease, I wouldn't have had a place to stay that night. And so I think just even going back to the video about how all of our races look different, how the things that we've been through, our familial upbringing, how they impact our life, not only with sickle cell disease, but some of these other socioeconomic disadvantages, these all play a huge role in adolescents and young adults care. And so that was really inspiring for me to just really look at this population a little bit more and decide how I could be an advocate for my patients that I see in the ER that come in sickle cell pain crisis, and how I could really support this population, and how that I can hope to dismantle some of the health-related stigma that this population faces. And the research supports that these are facts, these are true beliefs and feelings that this population has. And it also supports the facts that as providers, we do have bias, and it does play a part in how we manage care. So my hope from this conversation is just to really be able to do some of these things, educate ourselves and others, and just be aware of the care that we give, and see how we can really dismantle this and give equitable care to everyone. So I think this is my last slide, and I have 1,000 references. I would love to hear from anyone who has questions or concerns or comments about this very important topic.
Aubrey, I have a question for you.
Sure, I will do my best.
I think one of the first things that as clinicians and hospitals have done to support patients with sickle cell anemia is developing comprehensive treatment centers that uses the care of sickle cell patients using a multidisciplinary group, which is social services, medical, nursing, and to support them with the expertise of different professionals. I'm just curious, because I used to work with them probably 25, 30 years ago. From your experience, are you able to tell, looking at the United States, in the different states, have the number of these comprehensive centers increased to help support this patient population in terms of pain management and education? Because, Children's Hospital is very well known here because we have an exceptionally large sickle cell program for both pediatric adults. Have you seen that across the United States?
Thanks, Deb, for asking that question. I want to make a small comment, and Dr. Bell might be on the call, and other of you in the audience may know some answers to these questions as well. I feel like there is actual current work. I was reading a recent article that discussed kind of like a coalition of clinical settings in the Southern California, as well as here, to really help drive this comprehensive care. And I think it's definitely a challenge because with the increased life expectancy that we talked about, it's been a difficult transition in creating comprehensive centers that help transition healthcare from childhood to adulthood. But I do feel like the number of clinics have increased. I can't give you a specific number though, but there is work being done on that currently. I know even our hospital, I believe, is working with some centers in Southern California to kind of bridge out and kind of come up with a plan that benefits people all over the state. And I know this is happening in other places in the country as well.
Okay, thank you.
Hey, Aubrey, this is Mary. First off, yippee, I am so proud of you. And I want you to know that some of the first and second year grad students are listening in. And we're all so excited that you have done this presentation. So thank you, thank you, thank you. My question for you is, it takes a lot of bravery to be able to speak up in a group of, at one point, 59 listeners. How are you going to encourage other nurses to do the same thing?
Well, first was educating myself. I really didn't know a lot about the data before I actually, for those of you who are listening, I actually wrote my exit paper from my nursing program on the impact of health-related stigma on this population. And first it started with myself. It started with understanding the objective information, understanding the qualitative information that not only that I have experienced in the ER, but that the data shares. And so now that I'm beginning to educate myself and really stimulate the importance of learning more about this in myself, I'm able to go out into the community and with my colleagues and hope to educate them. And I'm hoping that this is going to be the first of many conversations, not even just about sickle cell disease related disparities, but just all kinds of different disparities. So I'm hoping that this translates to that in the future. But it starts, I truly believe it starts with yourself, educating yourself, being aware of your biases or just things that have kind of biases that have been sometimes ingrained in you for a long time, and then just giving equitable care to everyone that I see in the emergency department is where I'm going to start, and hopefully that branches out into some new avenues for change.
Yeah, and Aubrey, to add to that, I took care of a patient once with sickle cell, and I was precepting a new hire, and I was standing in there and we were just talking, and I said, you need to, when a sickle cell patient says they're experiencing pain, but they don't look like they're in pain, you need to realize that they live with this day after day. And that we need to believe that if they say they're a 10 out of 10, they're a 10 out of 10. And I stopped and I looked at the patient, and she was in tears. She says, nobody listens. Nobody hears that, yes, I'm a 10 out of 10. Yes, I can play on my phone or I can talk on the phone and I don't look like I'm in pain, but I am experiencing 10 out of 10. So it's important for us to realize that, these patients, there are definite stigmas. I had my own stigmas and my own biases. So I do think that we need to encourage our colleagues to listen to our patients, to understand our own biases, and figure out a way to kind of educate each other about this.
Hey, Aubrey, this is Madhav. Really, really excited to hear everything that you had to say. I'm one of the HEMONC fellows, for those of you who don't know me. I have a question about kind of with your own experience in the emergency room. I know in our discussions you had talked about some kind of shocking things that you've heard about patients with sickle cell and just the perceptions that some folks have. In addition to education, when you hear something that is, racially charged or really assigning stigma that, in the moment, do you have any experience with things that you can say to other people, other healthcare providers that you think have resonated, and perhaps things that haven't quite resonated? Any suggestions for?
I'm still learning that, Madhav. I'm still learning that, how to respond in kindness and to respond objectively to some of my colleagues or to some of the visiting residents who maybe don't deal with children as much or don't deal with this population as much, depending on where they worked before. And so I try to be very objective in my responses. So, like on one of my slides, if someone thinks that Black people just have thicker skin than white people, I would try to educate them objectively, and maybe even print out information or a study that shows that information is false, so that there's always an academic way to lead the conversation, especially because we work in an academic institution where people really appreciate that objective information. But I'm still working on that. I'm still trying to figure out how to be able to have these conversations. And I think there's a lot of institutions all over the country right now that are also asking themselves and have work groups trying to understand the same thing. Like, how do we talk about racism in a healthcare setting? How do we talk with this with our patients and our colleagues? How do we debunk some of the things that aren't true? And so I'm still working on that and trying to figure it out. And but as I figure this out, I will begin to share this with everybody else too. So hopefully we can work together as a team on that.
This is great. This is Lisa, and I am research, and I have such great respect for those of you in the ED. For about 16 years, I worked for the PCRC CTSI, and I was the primary nurse and nurse practitioner for sickle, actually. And your staff impressed me among many reasons. I know there was a study that came out from a former physician criticizing our own care in the ED, showing how poorly we did in pain and sickle. And instead of reacting, people got busy, and from the physicians led by Michael Bell on down, working with hematology, but nurses as well. I mean, I think nurses were on the front line, and Stacy and Fran, if some of you can say, you guys took that criticism and made sure you did it better. I, for one, is privileged getting to see these patients out in the clinic. And I used to say to you all and the people on 5 East taking care of them, if you could only see these people when they're well, because especially the teenagers and the young adults, how different they are. I mean, I think the 5 East nurses got to see that because they get to see them get better. But that just really showed me, you know, people that are chronic users of EDs and hospitals, especially pain, especially when our treatments don't really work for them, it's easy to get biased as a care provider because it's like, here they are again, and they're really annoying. And I just asked them about something and they got angry when we've got everything in the medical record. But I saw some of the most amazing, gentle spirits turn into terrible people in the ED. And I could only imagine how terrible that pain must be. So I had that privilege. And I've always used to say, like, if only the staff could come out and see them when they're well, you would really understand how terrible this disease is. And so that was my personal little statement and seed that I put in a lot of people, and people would go, oh yeah, I didn't realize that. I'm like, yeah, either you get the two types, either people are angry and like hitting the wall and not cooperative, or they're so internalized, the kind that Fran talked about, that they can barely talk to you or they don't want to talk to you, and angry. And I'm not surprised that the parents were angry because they're just tired of it. And you know how teenagers are, by the time they hit this terribly hormonal time, they're tired of it too. So we do have a lot more work to do. I have said multiple times, if this were women's disease, we would have treatments better than just narcotics that actually don't treat their pain. And so we have a lot more work to be done. And I have always been impressed with your staff.
Thank you so much. I really appreciate that. You're absolutely right. And that's why I try to definitely show that we sometimes only see them at one point in time, at one difficult period that they're in this severe pain crisis. And while I was doing my paper in grad school, I met someone who was trying to create, or who had created and was trying to initiate this community outreach program where we did set up meetings. This was prior to COVID, of course, where we did set up meetings with people impacted by sickle cell disease and the health community to kind of link so we could see them at their best, instead of always focusing sometimes in the emergency department, always seeing them at that one point in time when they're in severe crisis. And so there is so much work to be done, and I'm really excited to hopefully be a part of some of this work to just help to change some of these ideas.
Hey, I'm Brooke. I worked actually on 5 East hematology for 4.5 years, and now in the ED for almost 2. I think kind of piggybacking on what you just said and what Aubrey said before is personalization is an important part of it. I think that people come in with bias or see people at their worst, and it can be frustrating when they're on their call light every 5 seconds. But just saying like, hey, you know, what do you think sparked this, you know, this flare of your sickle cell, you know, this pain crisis? And sometimes it's social stuff, and that has to do with socioeconomic disadvantages. But just really talking, I think it helps the patient and helps us understand. And one thing we've tried to do, and I do call people out on, is instead of saying like, oh, it's a sickler, that is very depersonalizing. And I think saying it's a person with sickle cell, if somebody went around calling you a cancer or a migraine, nobody would be happy about that. And it's not very careful, you know, thoughtful. And so I think just trying to personalize and say this person has a disease, isn't the disease, is just one way to help, that we can at the core, wherever, help, you know, personalize the situation. But also just, yeah, asking people what they think caused, you know, their pain crisis. And sometimes you get into some social stuff, and we do and don't always have time for that in the ED, but I think showing you care helps put the patient at ease and allows you to like have a better working relationship with them in the ED and treat their pain better.
Thank you, Brooke. I agree. Sometimes in the acute care setting, we get so used to running around all the time. I personally had to stop doing that myself, because I would call people by their room number, or I would call the parents mom and dad when it very well could be grandma. And so I took their personalization away from them and assigned them a number oftentimes. And so I had to begin to do that work in myself to change some of those habits. And so I agree with you 100%. I thank you for sharing.
Hi.
Hey, this is C.
You can go ahead.
Okay, sorry, this is Carmen. Can you guys all hear me?
Yes.
Okay, yeah. So firstly, I want to say thank you to Aubrey for just like putting this out there and having this presentation. My name is Carmen. I myself am a sickle cell anemia patient or survivor. I've had 2 bone marrow transplants. First one did not succeed and the second one did succeed. So I do not have my crisis anymore. And I think going back to the conversation that was also mentioned by Brooke earlier on, it's that I think what helps to speaking from the point of view as being a patient, you know, when an individual is going through their crisis, going through their pain, it's one of the most unthinkable, most painful pain I could think of and I have ever experienced. So when you see patients coming in and they're just in so much pain, it can be easy to not to see them for their pain or not see them as people. Or empathize with them, you know, empathize with these teenagers, with these kids who are literally just fighting through some horrible pain. And that can like really make the difference when nurses don't choose to concentrate on the attitude or the demeanor that the patient is having because at that moment, they're just in incredibly like amounts of pain, like I've experienced it for myself. And I think just like educating more healthcare providers, educating more nurses, educating the public on how this can really affect individuals, and especially the individuals who are in pain, is like something that really needs to be put out more in the forefront. And even, yeah, going back to like not identifying these patients by their sickness, which is dehumanizing, you know, they're going through a sickle cell crisis and seeing them when they are at their best because you're only seeing them at their worst, but we wouldn't want to be seen or remembered when we're in our worst. But I think that's like really all important. I just wanted to say that and reiterate that. Thank you for letting me share.
Thank you so much, Carmen, and thank you so much for coming. I'm so happy that you made it.
Aubrey, I'm Kelly Poo. I am the director of the HEMONC BMT service line here at Children's, as well as the current interim CNO. And I just wanted to say thank you as well for this presentation. I think it's been a long time since we stopped and looked at all of the work that was done in the ED, and it's always good to revisit those areas. This brings one other thing to mind with me where I think that your talk that you gave today would be such a great benefit. As you know, we do have an adult population here as well. You spent time in our clinic, and we did a lot of work with the Highland ED around pain management and, you know, pain meds on board in the first 30 minutes and all that. And I think that those adult facilities, Sutter, Alta Bates, and Highland would really benefit too from looking at this, you know, one more time and seeing your presentation. It was really great and I really appreciate it. Thank you.
Thank you so much. I actually, as I prepped for this, I started bugging all the residents that I see in the core, in the ER. And so some of the Highland residents, I started to ask them, how do y'all treat this population? And so I actually have a connect who hopefully will be discussing this more. Highland is actually working on a protocol for their emergency department. So this is coming up and it just kind of takes these conversations to fuel this. But if y'all don't mind supporting me in this, I'll be kind of linked up with Madav hopefully, and we can see this through and make sure that other community hospitals are also doing the same.
Aubrey, go ahead. Aubrey, I was just going to say, you absolutely have done us proud. I'm so glad to have you as part of our staff in the emergency department. Certainly, we all see you as a change agent, and you know you are, and, and really look forward to great things to come. Thank you so much for doing this. This is a big thing. Good job.
Thank you so much for your support.
Very much agreed. Thank you, Aubrey, for sharing all of this information with us. And, you know, I think it brought up a lot of conversation, even here. So well done.